practical dates have started coming. All of you are going to have practicals in the last week of October. Okay, last week of October is your practical, and it is in an old format, no Husky, the conventional way, 4 cases, then afternoon surgical instrument tables, specimens, statistics, and viva. So as per all your request, we planned a practical class today, which is surgical instrument relevant to surgical oncology students and exam. This is a very tough topic. It's very easy to speak on, robotic or pancreas or HIPEC or trials, because a lot of studies, trials, PowerPoint is already ready. But to speak on this topic is very tough, because very few people spend a lot of time, photograph the instrument, build up a slide deck, and then able to speak. So my heartfelt thanks to Venkatachala, who is a professor and is a teaching program head of TRNB Surgical Oncology at Shankara Cancer Hospital. Very senior and renowned, excellent surgeon and a academician. In spite of being in NatCon, very busy, on this day he has agreed to take this tough class, which not many people can do this particular talk. So please utilize all the opportunity. As and when he beams a slide of any instrument, immediately if you have a doubt, put it in the chat box. Because once he completes the full thing, you would have seen 100 instruments and you will forget what to think of it. So you put it, once he completes the whole presentation, he'll open and interact with all of you. Thank you very much, Venkatachala, and heartfelt thanks from us, DNB board and students. Over to you.
Okay, thanks to the DNB board and Dr. Somsekhar for bringing me here to teach the students about the instruments. I'm trying to avoid the common instruments. What I try to those rare instruments or some controversies or some explanation is needed, so that you get a better knowledge about the commonly used surgical instruments. So as you go into any scientific instruments, livers, we will have 3 classes. The first is the where the fulcrum is in the center, as you can see from the example, like a wire cutter or a conventional wire cutter or a scissors or a needle holder or an artery forceps, where the fulcrum is in the center. Your input force is your hand force is at one end, where the notches are there, handles, and the tip of the instrument is the output force. The second class of instruments is where the fulcrum is in the hand and the output force is in the body of the instrument, and the input force, wherever like you try to do, the input force is in one end and the output force is in the other end. So that could be like the wire cutter here. The wire cutter will act like on the side. There is more work on the side than on the input force, like the end. The input force is here, the output force is here. The third class is like this, the forceps. The fulcrum is at the end. You have put the force input at the center, like you hold the forceps, and the output is at the tip. So the forceps tip here is the third class of instruments. So these are all the commonly used instruments, of these Iris forceps or Adson's forceps. Is the Adson's forceps, and this is the vascular needle holder used for all vascular suturings or microvascular anastomosis. So you know that there is a delicate spring here. You have to be as delicate as you have to be, because one thing, that there was a note put on our OT door that if you put maximal effort, there will be maximum trouble from the door. Means you have to be as gentle to the instruments and the OT doors as possible, so that you don't have to end up with damages. Each instrument costs around 5,000, so you have to be very careful. The common needle holder, the common artery forceps, and these are the tenotomy scissors. Not many will be familiar with the tenotomy scissors. We use this particularly for venotomy or plastic surgery dissections, saving the facial nerve or the recurrent laryngeal nerve in thyroid surgeries, parotid surgeries, and neck surgeries. This is something equivalent to iridotomy scissors used for making spatulations in ureters or for the blood vessels where you want to increase the diameter slightly before any anastomosis. Again, the common forceps come with different angles for different depths and different opticians, different surgeries. These are non-traumatic forceps. Something without a slot is called as the Russian forceps. We use these Russian forceps for particularly the lymphadenectomy, where you don't want to crush the lymph nodes. The tips of the tooth forceps or even the DeBakey forceps also may sometimes damage these lymph nodes tissues. So we would prefer to grab the lymph nodes with these forceps, Russian forceps. So as you can see, these are the commonly used vascular instruments. You know, there are varieties of vascular instruments that we come across. The common ones are the bulldogs. The bulldogs, you know, come with short length, like 2 inches, 3 inches, and they will be curved, they will be straight. So depending on what work you're using, like principally used on small arteries or the veins. Veins are collapsible structures. They are thin walls, so bulldogs are better. We don't use these. The top instrument here, this is the Satinsky forceps, as you know, as used not only in the blood vessels but also in other places. The other places being we apply it on the esophagus, cut into the esophagus, so that before the anastomosis, particularly in doing an abdominal esophagojejunostomy or esophagogastrostomy, the esophagus is clamped and held so that it will help you in holding it for the anastomosis. The tips of these vascular instruments are so delicate. The slots are all ridged vertically, so they are actually non-crushing. You know that blood vessels and intestines, they need non-crushing instruments. So basically, esophagus or any major vasculature be much of crushing effect. You know that there will be atheromatous plaques in many blood vessels. Even a non-crushing clamp like Satinsky can cause serious damages to major vessels like the aorta. If there is a atheromatous plaque, it can get dislodged without your knowledge. Patient later can have embolism and vascular occluding event, which if unrecognized can result in gangrene. So we have to be very careful in using these instruments, even though they are not occluding. And there are other vascular forceps similar to the Satinsky called Cooley's and Allen's. They are mainly used where you want to hold the end of the transected blood vessels, whereas Satinsky can be applied onto the partial wall of any blood vessel also. If there is a rent in the vena cava, you can apply a Satinsky which is smaller than this and repair the defect and then release the Satinsky clamp. The advantage of the Satinsky clamp, as you can see, is that the tip of the Satinsky clamp is a bit curved, like almost like a U shape or a L shape or a J shape. So that helps in holding the lateral wall of blood vessels, or even we can apply it on rectum also. If you don't have the rectal clamps, you can apply it on the rectum. Rectal clamps are almost similar. They are more heavy. They have a right angle tip here. The right angle tip here with a heavier instrument with again vertical serrations in the axis of the instrument. That is called as the rectal clamp. We use rectal clamps before transecting. Suppose you want to do open and so anastomosis, then the rectal clamps will be useful. 2 rectal clamps, one on the top and one on the bottom, proximal and distal ends, and transect in between. Why I am stressing more on these vascular instruments is many people don't know about the names of these vascular instruments and where they have to be used, which instrument has to be used where. If you don't use the right instrument, if you don't have the right instrument, then you will not be able to achieve quick hemostasis. So the common, when vascular instruments are spoken, like we get these DeBakey forceps. DeBakey forceps has very fine teeth in 3 rows. Okay, these 3 rows are useful in not only holding the tissues like a tooth forceps, but also they are delicate. They won't damage the tissues much. So traditionally, what has happened is from the conventional tooth forceps or the non-tooth forceps, we have moved to DeBakey forceps for most of our surgeries. Why the advantage is that this can hold tissues like a tooth forceps without damaging the tissue much, and it can be delicate, but the tissue won't slip. So if for the last 15 years or 18 years, I'm refusing to take the plain or the non-tooth forceps because the tissue generally slips easily from that with the forceps, and this forceps the tissue doesn't slip easily and it's not damaging. The other advantage is you can hold this, you use this tissue to hold even the intestines as well as the blood vessels. So the damage to the blood vessels is least with these instruments. They come in different lengths. We keep 10 inches, 8 inches, 6 inches, so that it's used for various of our surgeries. So commonly what we do is that so the instrument is 6 inches or 4 inches is generally used for the surface. Even if the instrument goes 1 inch shorter or 2 inches shorter, you have to bend 2 inches. So adjust the instruments according to your comfort. These instruments are not so expensive that you have to compromise. You're bending 2 inches in the long run may be troubling you, or it can cause elbow damages. So surface 6 inches instruments, and for intra-abdominal 8 inches instruments. Even the scissors, forceps, needle holders, everything must be 8 inches for the depth. As you come to the surface, whether it is Prolene, BDS or Vicryl or Monocryl, we generally go into 6 inches instruments only. The only thing is, with the needle holder, you should not lock the needle. If you don't clamp the needle, then the instrument won't get spoiled early. Its life can last longer. As you go to the depth, like deep in the pelvis or like in the diaphragmatic hiatus, through the diaphragmatic hiatus, we want to take stitches, we use 10 inches instruments. So these are our common retractors. The retractors on the B is the Morrison's retractor. You know that Morrison's retractor was traditionally used for clearly cholecystectomy. The liver side or is before the gallbladder is accessed. You should first apply Morrison's retractor, or when peritoneum is open, apply Morrison's retractor, dissect everything, and then use the Dever's retractor. Now these days, everything starts with Dever's retractor or self-retaining retractor. Use of Morrison's retractor has been very less. And the other one, you know, that something confusing to Morrison's retractor, it also comes with a slot. You can apply to any retractor, self-retaining retractor, and lock it. The Doyen's retractor, the Doyen's blade, as you know, it has a C-shaped, U-shaped blade at the tip. That blade is used to retract the bladder. It is not right angle, so the curve actually should fit into the suprapubic area where the bone is comes first, and then the peritoneum. There is no muscle to retract in that area other than the lateral edges of rectus muscles. Whereas here, this is mainly used to retract the muscle. So the trauma must be less. So the Doyen's retractor is used to retract the bladder. So self-retaining cusco-speculum. The fulcrum is here. The liver mechanism, the screw and the liver is here. As you close it, it opens. As you open it, it closes. So this self-retaining cusco-speculum is used for the vagina. So after, if you want to use the Sims speculum, just the inspection, use the anterior vaginal wall retractor, and the Sims speculum is applied. It comes in different lengths for different depths. So this is for visualization, or if you have an assistant can hold one blade, you hold the anterior vaginal wall retractor, visualize, do biopsies, colposcopy, whatever. For hands-free working, use the cusco-speculum. It comes in different lengths and different materials. This is stainless steel medical grade. So what you see could be around from 5 inches. We also have some 7 inches long for deeper vagina where the patients are obese. You want to access the depth before you visualize the cervix or you do a DNC. So also we have glass self-retaining speculums. They are not as strong as these instruments, but those glass self-retaining vaginal speculums, they come with longer blades, so we can use them for certain patients. Or if you are trying to use laser, you know that metal instrument should not be used. So laser, with the laser comes the plastic or the glass instruments. Then coming to some things with which works with the orthopedics. Already I told you the wire cutter. There is a slot here to cut the wires. There is also a slot here to cut then these are the curettes, the scoops. One will be a bit blunt, the other end will be sharp. You can scoop out tissues from the diseased bones before any other procedure is done. Also, abscess cavities, you can gently scoop out those granulation tissues and necrotic tissues. This is again, we keep these things and ask people what are all these things. There will be confusion. This is a wire cutter. This is not a cutter. This is not a cutter. This is bone holding forceps. You know that whenever somebody is doing some work on some bones, long bones particularly, they can use this bone holding forceps. The edges will hold it here. The screw will tighten the bone. So you will have a good grip on the bone while you are working. So again, you know that this is used in head and neck surgeries. It's a mouth gag. Okay, so you apply it. Generally, it comes padded with a plastic or a rubber material so that you don't cause much damage to the dentition or the lips. So this is applied on the teeth, and then you open it like a mastoid retractor, and it acts like a self-retaining mouth gag. So some people use plastic mouth gags. They are particularly useful for the cheeks. If they can't keep the mouth open, particularly when there is trismus, you can use the bite blocks or the dental blocks, which come in 3 different sizes. But this is used in most mandibulectomy surgeries, or when there is trismus, you want to excise something in the oral cavity. Then these are the anal speculums. The anal speculums, again, like they come with a screw here and the 2 blades. You can place them inside the anal canal for lower you can excise them, where this is a self-retaining anal speculum. Similarly, you also get a miniature one which acts like a self-retaining nasal speculum. Self-retaining nasal speculum is almost similar, except the blades are slender and it's a much smaller instrument than this, and it comes with a handle like this. It comes with a handle like this, so that people can hold the instrument delicately. There is also another instrument which I don't know, many of them may not have seen. Dr. Somsekhar knows about it at Manipal Hospital. There is called a cervical speculum. Cervical speculum is a very small speculum like this, which is placed inside the endocervical canal. You can open it slightly for any abnormal pap smears, but there is nothing seen on the outside of the cervix. Endocervix, if there is a lesion, you can take finer biopsies from the endocervical canal. So commonly people forget these instruments. These instruments open a bit different than the other instruments. This is a tracheal dilator. This is a cricoid hook. I have kept this retractor so that people should not get confused on what is cricoid hook. As you can see that the cricoid hook here has a sharp tip and a single hook. Whereas this retractor, this is a tracheostomy retractor. It comes with 2 hooks. The 2 hooks is, if you cannot place, they're wider, so you can place one hook under the muzzle first, and then the other hook will follow, so that the strap muscles can be retracted with these 2 hooks. So this is a tracheostomy retractor. The cricoid hook, generally we ask them to keep at least 2 cricoid hooks. The tip must be a bit sharp, because under the isthmus of the thyroid, you lift the cricoid, stabilize the trachea before you take a inverted U cut on the trachea. So traditionally, either putting a transverse cut or a cruciate cut on the trachea to create a tracheostomy is not followed, because later on, when the tracheostomy tube has to be changed, if the ward duty doctor is struggling, he may pass the tracheostomy tube into a false passage and cause choking, and the patient may die. So we take a inverted U cut on the trachea and the tracheal flap. If it's not a permanent tracheostomy, we are going to suture the flap to the skin edges, inferior skin edge, so that later nobody, if somebody is struggling to pass the tracheostomy tube or change it immediately, the tracheostomy will not close. You will have enough time for somebody to come and change the tube with the flap being sutured to the inferior edge. Please follow this strictly. Even one patient lost with the bad management of tracheostomy is not acceptable. The tracheal dilator is unique. There is spring here, but unlike other instruments, if you close this will open. Whereas you have seen the artery forceps, the scissors, when you close this, the instrument adjusts the approximate, the tip approximate, and then you can either hold the tissues, you can cut, suture, whatever you want to do. But here, because we are used to instruments, all these artery forceps, needle holder, and scissors, we are used to close the instruments for an action. A tracheal dilator, if you try to close and the tip closes, then you will be struggling. So for that reason, they made it unique so that when you close these instruments, the blades are on parallel sides. So when you close the instrument, the tips open. So that is what you need in a tracheal dilator. But you are taking a U flap, inverted U flap, and suturing it to the skin. The tracheal dilator will not be useful. Tracheal dilator may be useful only when you want suddenly to put a cruciate incision, dilate, and put the tracheostomy tube. So for my last many years, the tracheal dilator has not been put into use in our tracheostomies. Coming to the abdominal retractors, as you can see that this is the traditional ball 4 abdominal self-retaining abdominal retractor. How you identify is two handles like railings where the engine moves on railings, the blades move on these handles, and then the blades, the actual retracting blades, they are not solid. They are U-shaped, and then there is a slot so that it doesn't damage the muscles much. And then the retraction is also, you can widen this. Sometimes they come with a screw. You can tighten it at that point, or conventionally we take a bandage and tie the bandage here between this and this, so that you can keep the retractor in position while you do the rest of the work. Here on the under surface is a screw. You can fit a Doyne's retractor, Doyne's blade, any else retaining blade to that. So it works as it creates the horizontal or vertical wound into a circular wound. So the traditional circular retractor, many people are comfortable with this for big abdominal surgeries, renal transplants, etc., where they put this retractor, circular retractor, and then the blades in 4 directions. All the 4 blades must be used for stabilizing the abdominal incision. So these blades, depending on the depth of the wound, this is fixed. The circular rim is fixed here, whereas this, you can adjust the blades according to the retraction needed, and then you can finish the work. Circular self-retaining abdominal retractor. This is what we have here in, we routinely use this for our pelvic surgeries particularly. This is the O'Sullivan's self-retaining pelvic retractor or abdominal retractor. The advantage of this O'Sullivan's retractor is that once these blades sit on the rectus muscles and retract them, so there are 2 screws on both sides, so it has 4 fulcrums or joints where the retractor can open. So there are 2, conventionally they give 2 blades with this. You can have add more blades also. Among these 2 blades, what happens is one is sitting here on the bladder side and the other on the bowel side. So what you do in a abdominal pelvic surgery is that you want the bowel to go out of the plane. Conventionally, what we use is either the Sargent or the malleable retractor. The malleable retractor tips are placed in the iliac fossa on both sides, and then you give a V-shaped bend so that the bowel stays in place. But here, the advantage is that you don't have to struggle with all that. One retractor, it will come for many years, although it's a bit expensive. You pack the intestine and put this blade and then apply this screw. And here, the bladder sometimes can be retracted with this blade so that you create a wide space, a sustained space, so that you can visualize inside and do a proper pelvic surgery, Vardhaims or rectal surgeries. And depending on whether it is a rectal surgery, then you keep the sigmoid colon free. If it is a gynecological oncology surgery, you pack the sigmoid colon also. So nothing is interfering. Your hands are free. You can work without an assistant also. But be careful that these blades, when they are applied in too much stretching, it can stretch the psoas major muscles and cause severe pain in the post-operative period, because all retractors open surgeries that the retractor stretching causes more pain than actual incision pain. So if you do a laparoscopic assisted or robotic assisted surgery, you do only the terminal part by removing the specimen or something using a open incision. The pain is still less because the retraction time is less. The blades can hit the psoas muscle, stretch on too much on the oblique muscles and cause neuropraxia, with many patients complaining of weakness and pain in the lower limb muscles after surgery. So you have to be as gentle and careful with these retractors. Then comes these, you're all, most people will have at least one pair of Thompson's retractor in your hospitals. You know that the Thompson's retractor comes with two bars, one bar here, one bar here. They're fitted to the OT table after draping, so the equipment remains sterile. The liver retractors, there can be abdominal wall blades only for the abdomen. If you want something gentle on the bowel, you can use this fan-like retractors. Similarly, you can have extension blades like this. One handle is going like this, one handle is coming like this, or it's a single handle connecting two pillars. Then you can use another handle below the this thing using various clamps. So the clamps have to be put well before you fit the pillars and these handles. So you see that the clamps are all in, and then the handle, these handles are the arms. The arms are put. You can use arms like this, different depending on your requirement. The cost varies, and you have to choose the number of arms. The number of you can use one Thompson's can be split into two. You can use only one pillar if you are doing a radical cholecystectomy. One pillar is enough, and one blade and one retractor or two retractors are enough. So you don't have to use this entire equipment. So one equipment can be used in two surgeries simultaneously also. And these arms will help in creating the wound into a circular this thing. Or you can use two arm Thompsons. Many hospitals, higher end centers have two Thompsons, one Thompson here, one Thompson at the pelvis, as you can see in this here. You can use a pillar here. Next onto that pillar. So there are two Thompson's retractors and working simultaneously, and then the retractor blades can retract the upper abdomen, lower abdomen. You can do after the cytoreductive surgery, IPEC, or even for cytoreductive surgery also it will be useful. You have to understand that longer the retractor time, the more pain will be for the patient. You will have a lot of post-operative pain because of muscle stretching. So use them judiciously. Many people would not have seen this. Not only the doctors, the nurses also wouldn't have seen these instruments. These are called rib respiratories. What is the use of rib respiratory? You see the handle, the hook. The hook is where it goes. This slot is right hand, and this is the left hand. They are placed like that. Why right hand? You are doing a right thoracotomy. The nerve is here. Means the rib. You imagine the rib is here. Now the rib respiratory goes through the under the periosteum. The nerve being here is saved. It is not damaged. It goes and then takes a clockwise rotation. One clockwise rotation. Then this tip comes onto this side, like it becomes like this. The nerve will be on the undersurface of the rib, and then you shear the periosteum. You strip the periosteum using this rib respiratory. So this is the right handle. Here it's used for the right thoracotomy. This is used for left thoracotomy because you stand on the left side, and then the nerves are on the undersurface of the ribs, under edge. So you pass it like this, so the nerve is saved. If you try to use this, you won't be able to pass because you have to pass it from the top of the left side of the ribs, which can damage the blood vessels. And then this is more useful for the left side. Again, you can save the neurovascular bundle on this strip of the periosteum. Before you use these instruments, these are the rib cutters. You can see that the rib cutters come with those slots. This is the cutting edge of this. This is the blade. It is not very sharp, but it has a crushing effect. Generally, it doesn't cut sharply. The rib end will be traumatized, means it can be crushed or it can be ragged. You can use a traditional bone cutter to cut the ragged edges of the rib so that they are in sharpened. And over a period of time, we are not using much of rib shear or rib cutters because what we and myself and Dr. Somsekhar follow is we go all the way up to the angle of the ribs into the close to the quadratus lumborum muscles, erector spinae muscles, so that you cut the pleura up to that area. Anteriorly also we try to take it as far as possible. And usually we are doing surgeries in the thorax using mini thoracotomies. So you don't have to divide the ribs. So rib cutting and shingling, it's called, taking a segment of the rib, particularly the lower rib is taken because you to get more access into the thorax when there are large tumors. For routine lung surgeries or esophagus surgeries or mediastinal tumors, other than the use of pads, we are not doing rib cutting because mini thoracotomy is enough for most of these surgeries. So this is again the conventional mastoid retractor. As you can see, the blades, they come in different. The instrument comes in different lengths, and the blades also you can have 3 or 4 hooks. They are used for our chemoport surgeries also. Vascular surgeons use them commonly. Self-retaining retractors, so that you get into the blood vessels, and you can for all the vascular surgeries as well as mastoid surgeries, you can use these instruments. So this earlier I had shown you the Cuscos self-retaining speculum. This is the anterior vaginal wall retractor. You can use it for retracting the anterior wall of the vagina. Grab the cervix with the anterior lip of the cervix with the valsalum, then the uterine sound. All these are important in DNC. So anterior wall retractor or a Cusco self-retaining speculum. With this anterior wall retractor, always you have to use the Sims speculum. Then the valsalum to hold the anterior lip of the cervix. The uterine sound must always be used to assess the angulation of the endometrial cavity, whether the endocervical canal is stenosed or not, whether the instrument goes freely inside. If the instrument is not going freely inside, you may have trouble in when you start dilating the endocervical canal. If you are not using the Agar's dilators properly, what may happen is you may perforate through the cervix also sometimes with excess force if it's diseased, if there is tumor in the cervix. So, or you don't know where exactly is the endometrial cavity perforating the. So, always the uterine sound must go in. If the uterine sound doesn't go in, you see that it is a bit L-shaped, so that it's angulate in the anteverted uterus, it goes easily. If it is retroverted, you will get to know by the difficulty in insertion. If you cannot insert the uterine sound easily, please don't dilate the cervix. Please don't try to do anything. You better advise the patient hysterectomy and frozen section rather than struggling and perforating and ending up spilling the tumor into the peritoneal cavity or creating the pelvic abscess. So the Finiscito thoracic retractor, thoracotomy retractor, or commonly called as the rib spreader, you know that these come as this is again the handle on which one blade moves, the other blade is fixed, like the mouth, the mandible moves, whereas the maxilla is fixed. These are the blades to retract the ribs. Once the thoracotomy is done, you place these ribs, and then there is a lever here, the screw. You try to open it, and then the blades spread apart. So in our GCRI Cancer Center, we have seen 2 types of Finiscito retractors. Means that one is for the right thoracotomy and other is for the left thoracotomy. If classically, if you see that if this tip, this is the tip. If it is towards the axilla, that means it is that side thoracotomy rib spreader. So this generally what you see in all the hospitals these days is only the right thoracotomy retractor. The left thoracotomy retractor is hard. It is just a mirror image of the right, but it is not seen much often these days. So whatever is there, people use only the right thoracotomy retractor for both the right and left thoracotomies. But if you can ask your surgical instrument supplier, if they can make a mirror image of the right thoracotomy retractor, you will get the left thoracotomy retractor. The advantage is this faces the axilla rather than hitting your hand every time you operate. If you put the same thing on the left side, it will keep troubling you. So this, everybody would have used this, the lung retractors, and these are the rib cutters. Again, you see that the bone cutters, rib cutters, they come with 1 fulcrum or 2 fulcrums. Here, you see that there are two fulcrums. These screws are different. There is a joint here. So when you press the handle, compass like a diamond, it opens. So it gives extra length to this instrument. Mayorner or Jowell's self-retaining thyroidectomy retractors after robotic or minimally invasive thyroid surgeries, or because we put very small incisions on the neck and then we take stitches at the edges of the wound. We stitch the platysma to the drapes. So we are not, traditionally, even this instrument has become only a museum piece. We are hardly using these instruments these days. So all the good instruments, which were earlier commonly used, have become less common these days. Again, these are all the one of the punch biopsy forceps. That in various places with the cervix, the punch biopsy forceps, the tips come in different different types, cup, or it can be like something like this, like a crocodile mouth, or it can be like, you have seen the cervical biopsy forceps with really so stout, that a big chunk of the cervix can be taken. So those instruments are not routinely used, but these punch biopsy forceps come handy in the OPD, where every surgeon must possess them in the OPD itself. Under local anesthesia, you can take many biopsies. So, going through all these instruments, I thought, no, I would like to put some energy sources. Many people in some hospitals may not have seen these things. Let's a short discussion. That you people read a lot about energy sources and use them also. That this is the harmonic or the ultrasonic shear. Okay, and this is the thunderbolt. So the thunderbeat. See, all these use different energy sources like uh, the the harmonic shear or the ultrasonic shear uses ultrasonic waves. Then you have the ligature. Ligature uses this thing, microwave. The cautery uses electrical current. Again, this thunder beat. You see that these things are prepared. You know that the ligature was bulky, so ligatures cannot be used for fine dissections as well as fine tissues. The tips vary in size, and that's that it is an advancement over all these instruments. So use that the tip of this instrument and the delicate things. There's a competition to the ultrasonic shear. These people, they are trying to push instruments into the market with new designs, but costs also keep increasing. And you know that this is as a Teflon coating at the tip, and then you can use these things for laparoscopic surgeries, particularly. Harmonic or the ultrasonic shear comes with this is the lock which used to tighten the instrument properly. If the instrument is not coupled properly, then the it won't work properly. So you have to actually fix this properly before you start using the instrument. And this is for, you see the handle, it's very clearly a open surgery instrument. Sometimes the tip comes a bit curved, that is called as harmonic ace. This is harmonic wave. And then you know that laparoscopy, you have the long instruments, harmonic or ultrasonic instruments for laparoscopic surgeries. So you should know how to use. This is fixed handle, this is the mobile handle. You have to use it delicately. The more the force, these instruments get damaged, they're expensive. So if you're delicate with them, they will come for long use. Also, you should not use the tip. The tip you should be very careful, very delicate, and you should not touch any metal object with these tips, because with any contact with metal object, the 20,000 cycles per frequency, the tip can get damaged and it can break. So this is a mobile tip. It is a dummy tip. Without this tip also, you can use this working tip or to get the necessary coagulation or the cutting effect. The cutting effect and the coagulation means minimum means coagulation, maximum is cutting. But this is given only so that people are traditionally used to holding the instruments like forceps, like artery, like so that this gives an extra comfort to the surgeon. And now this instrument, the staplers. Staplers, you know that they come as linear cutter staplers or end-to-end anastomosis staplers, EEA staplers or the circular staplers, or the side-to-side anastomosis or transections, that is the linear cutter staplers. This is a circular stapler. They come in different colors. You can see here red, blue, or green. That means it is either depending on the company, it can be either 25 mm head size here. This size is 25 mm, or it can be 29 mm or 33 mm. For esophagus, generally we use 25 mm. For the rectum, we use the 29 mm. 33 mm earlier we used to use, but you have to stretch the rectum, the anal sphincter so much before insertion of a 33 mm that a patient may end up with incontinence. At the end of the colorectal anastomosis using stapler, the patient may have incontinence for flatus but should not have incontinence for liquid stools, because after colorectal anastomosis, post radiation, there will be more liquid stools than solid stools. So we should be very careful in choosing what is the edge size. 29 is enough for most of our anastomosis, not necessarily use 23. So you know that there is a handle, there is a lock here, and this curvature is for the rectum, because the sacrum, the pelvis has a curvature on the sacral side. Whereas for the esophagus or any intestinal anastomosis in the upper abdomen, you can use a straight handle. So how you apply is you have to remove this anvil, the handle, apply some lubrication, pass it inside, read the instructions, because 3-4 companies produce the work mechanisms may be slightly different. Read the instructions or keep the company person initially when you use some new instrument. So once the anvil is removed, you know that this anvil is used for the proximal end using a purse string suture. Then this goes through the rectum, the main handle goes through the rectum with the pins being on this side. This is a green plastic piece. We can use it, apply it on the tip of this instrument so that it doesn't cause much trauma to the rectum when you are passing it uh, through the transected end of the rectum, which is generally stapled. So once the tip has perforated through the rectum, you know that now by opening or closing, you can push the tip of the instrument through the transected staple lined rectum. So then you push the anvil along with the proximal colon down. Then this can be, you can crush this handle and then fire it. So the two ends get approximated. Important thing is once the ends are approximated, you know that the purse string suture gets cut, means the blade has got deployed. The blade has not deployed properly. There may be a area of the anastomosis which is not transected. The blade may not have functioned fully. So you should be gentle in that position. Open the blades, put this lock back into position, and see whether the instrument rotates clockwise and anti-clockwise 1.5 turns. Once it rotates comfortably, means the blade has worked well. The donuts would have come into place, the proximal donut on this side and the distal donut on this side. If the handle is not coming out easily, that means there is some damage to there is somewhere the edges of the anastomosis have not approximated, or the blade has not fired properly. You can, holding the handle, somebody can come from the inside and check whether there is anywhere where the anastomosis is not happened properly, and same time take some stay sutures so that you know where to use some extra sutures if the anastomosis, there is a rent in the anastomosis. Again, before using the circular stapler, this instrument is used. Either you can use this, or if the transection is at the rectosigmoid or upper rectum, you can use a traditional linear cutter. You can also use a endostapler. Endostapler comes with some articulation, but you know they are expensive. Even this is also expensive. It costs around some 35,000. So it can, the only advantage is that you can use it 1 or 2 times. If you try to use anything beyond 2 times, this instrument doesn't work well. Then you may not end up in having a good transection on the rectum, or the blade may not fire. So you don't use it for too many times. You can use a linear cutter, sterilize and reuse it, but this is a bit more difficult. It has always troubled us when you try to reuse it. So the blade comes here. So you know that there is a slot here to transect the rectum. This curvature goes along the curvature of the sacrum. So once you have the rectum is inside this, you can decide 2 centimeters or 5 centimeters, wherever you want to transect the rectum according to the requirement. Then you have to push this handle. This handle will take the metal rod to the tip. Once the tip, this is in place, means the rectum will not slip. Then you can adjust this instrument to wherever the transaction limit you want to achieve, and then you apply this. This handle approximating to this means it will approximate the tissues. It will not fire the stapler because it is a double row staplers on both sides. Both ends are sealed. So this will lock the tissue, and then once you are fine, you want to fire, you can apply this handle and fire. Fire means once you apply, it should be a crushing and a click sound, and then with the click sound also there will be a transition of the tissue in between the staple line. If you are in any doubt, you don't want to fire this, adjust this, put this back into place, put the lock back into place. So you can press this handle, or before releasing also you can press this handle. So this opens, and then you can take it out, adjust it. So the linear staplers, you know that, no? Linear staplers, I have put here linear staplers with reloads. A different this thing you can adjust. There are some staplers come linear is for the GIA stapler. GIA is the GI anastomosis. So you can apply the linear staplers to transect, as I told you, to transect the rectum also, to transect the bowel, before you use the same stapler for a T-shaped anastomosis or a side-to-side anastomosis. Some of the companies, they come with, it comes as blue, white and green. Where do you use white is used for the blood vessels. So blood vessels means the mesentery, if somebody wants to transect using endostaplers, they can use that. Or you can transect any blood vessel like in the thorax or the lung. To seal the lung, no, you need airtight closure. So, and also the blood vessels, you need watertight closure. So all these blood vessels can be well approximated. Even the lung transections, if there is no fissure, you can create a fissure using this white cartridge. So if you are doing thoracotomy or vascular work, please keep white cartridges, either endo or open. So for the trachea, you know that the tracheal anastomosis is there. That stapler can also be used to transect the end of any bowel like the rectum, or the tracheal, trachea and the bronchi also you can use the TA stapler. So TA stapler comes as like the 45, 35, depending on the requirement, you can use them. And but for the blood vessels, even the pulmonary artery, you know, the pulmonary artery is not as thick as the aorta because it carries it's a low pressure system. So it's thin walled structure compared to the aorta. So you can use this for the white itself for the pulmonary artery also, which gives a very good watertight closure. So good hemostasis is achieved. The blue is used for most bowel anastomosis, include gastric transection. So the green is the blades or the tip of the pins are longer. All these is that it's not the width of the pins, it is the depth of the pins that matters, because blood vessels you need thin pins, 1.5, 2.5 and 3.5 mm. So green is used for thickened walls, like if there is gastric outlet obstruction, you cannot use a blue one, you can use a green one. Thickened rectum, you can use a green one. Otherwise, conventionally, blue will suffice for most bowel transections. And there are some companies which come with depth adjustment, like the pin's length we can vary from 1.5 to 3.5 millimeter, but there are positions before you can adjust the positions here, green, blue and white. You can adjust that position before you fire the stapler, so that one handle will give you all the benefits. So you don't have to use three different colors of cartridges. One cartridge can serve the purpose. Again, so delicate, you know that most laparoscopic instruments, you know that the Maryland dissector, the scissors, you're all familiar with them. This is a laparoscopic handle with a lock. The two different types of locks will be available. So locks will be just to hold the bowel. So Babcock, hold the bowel with these things. They are bowel handlers or the bowel graspers. The bowels, you should handle them atraumatically. So you can use this on the bowel, grab it, lock it so that it stays in position. You see that the tip is like a cup, it is a bowel grasper. these instruments no, may be very rare. You may not get to see them in the exams, but at least you should know what these instruments are. This is both these instruments are used in prostatectomy, radical prostatectomy, open surgery. The advantage of this instrument is that it is placed on the dorsal venous complex. You know that before you do a radical prostatectomy, you have to control the dorsal venous complex. Without that, if you transect or to use it with a cautery, then it may tear and then there will be a severe bleeding, very difficult to control behind the bones. The cave of Retzius, behind the pubic bones. So you pass this screw will sit on both sides, the instrument plates will sit on both sides of the dorsal venous complex. The dorsal venous pedicle will sit inside this. So you can suture the dorsal venous pedicle, both sides, with somebody retracting using this, and then you can divide the dorsal venous complex. After that, now once you have transected the urethra, means the membranous urethra at the neck of the tip of the prostate, apex of the prostate. Once you have transected, know that you will pull the Foley's catheter and keep it in position. If there is any hemostasis needed, you will inflate the bowel, the bulb. The bulb will press on the dorsal venous complex for temporary hemostasis. While you use this tip, there is a groove here at this tip. That is the advantage of this tip. This groove will go inside the prostatic urethra. This tip will go inside the prostatic urethra. Once this tip is inside the prostatic urethra, you will retract the prostate and save the the nervae irrigentis, that is they are situated at 5 o'clock and 7 o'clock positions behind the prostate. So the neurovascular pedicle will be preserved there to avoid damage to the nerve structures. Again, these are commonly, this instrument is used. It comes in two sizes. They are Imolo clip applicators. You know that Imolo clips are fibrin clips. They are absorbable. So this is the purple is a 10 mm clip. 10 mm clips are used for most it's absorbable, so you use for most vasculatures. Whereas with 5 mm tip we try to use on delicate structures, delicate blood vessels. Whereas the 10 mm instrument needs a 10 mm port, 5 mm instrument can go through a 5 mm port also for like if you are using the harmonic also, some people use the Imolo clips on one side. If you put the Imolo clips on one side, what happens is that you are comfortable, at least you can sleep comfortably, there won't be any bleeding from that side. The patient side you can control with, secure with harmonics. Okay, so again, you know that needle holder slot is for the needle, and you know that these are the locks, press and release, the spring effect. These are the one of the two or three varieties of needle holders that we get. You know that there are needle holders manufactured which lock the needle. So by pressing and holding, the needle will stay in place, but you don't have to hold the needle repeatedly. There are such types of needle holders are also available. These are the common needle holders where the needle will sit here to suture, do endocarporial suturing like vaginal vault closure or bowel anastomosis or some closing the bowel rent in the bladder or bowel. So there are different types of vaginal manipulators when used for laparoscopic or robotic surgeries. This is one variety of them. As you can see that it comes with an handle. This is the handle, and then this handle will have a knob which rotates. This rotation will change the direction of the tip. So if the uterus has to be anteverted, retroverted, depending on your requirement, you can adjust this position. This tip goes into the endometrial cavity. So before you place this position, this instrument, you must do a dilatation, or you do create a laparoscopy. That means the pneumoperitoneum. Put the scope inside, and then you go down. Once you go down, using a Cusco speculum, you dilate the endocervical canal. Once the endocervical canal is dilated to this size, then you either the largest Egar's dilator or one size below you will be needed for this dilatation. So this goes inside this. The plastic, the white material sits, around the cervix in the fornices. You know that when you cut the vagina, you need that the pneumoperitoneum must not be lost. So this protects that. Okay, so then there are other types of handles. Sometimes before for extracting the specimens also you.
Dr. Venkat, are we audible to you?
Venkat, can you hear? I think we lost little network. Venkat? Venkat? I think we lost the network from him.
Yes, sir.
Different types of uterine manipulators I mentioned. It's the
Yeah,
end
you
of it.
completed this. You told how to insert everything. Next slide.
Yeah, correct. So the thing is that people must attend all the department postings because different instruments are used in different postings. They will be familiar with the surgery, the steps, and the techniques, the instruments. So they should know the names of the instruments and the. If they don't know the names, at least they must identify the instrument, know the purpose of it, how to use it.
Correct. Now there are some questions in chat box.
Okay.
Maybe you can open both Q&A and chat box. Both.
This is I have to end this.
Yeah, you can end it. Yeah. Stop screen sharing. Yeah. Okay. Okay. Now both some Q&A and chat box they have put the questions. You can just open both of them.
What if there is I could see one question here.
Oh,
What
okay.
if there is no donut after circular stapler is fired? So stapler is STAPLER, stapler. So it is if there is no donut, it is unlikely that there will be no donut. If their anastomosis is complete, there will be a donut. The only problem is that the donut may not be complete. So what happens is you have to see exactly whether it is the proximal donut or the distal donut which has been troubled. If there is a semicircular donut and a part of the this thing there is a defect, there are two ways to see this. Either you can, if the anastomosis is accessible easily, you can see all around the anastomosis because you know that before you transect the rectum, you put two-stage sutures using 2-0 silk. So using those as traction, you can see whether there is any defect or whether there is any problem, particularly posteriorly, if the anastomosis has not come well. If you have done a good approximation of the edges before you fire the stapler, always confirm that the edges are approximated well before firing the stapler. There is no soft tissue or fat in between. If you are comfortable, the anastomosis is fine. If you have any doubts, you can take few seromuscular stitches in that area. If you are still in doubt, you can apply a bowel clamp proximally on the sigmoid colon and using a Asepto syringe. You fill the pelvis with saline first and then Asepto syringe, just air in the Asepto syringe. You try to insert it into the rectum and gently inflate air. Don't try to be very aggressive. Just gently inflate air into the rectum. See whether there is any bubbling. If there is any bubbling from the anastomotic edges, means there is a dent. You may have to take few extra stitches there. If there is no bubbling, if you are comfortable that the anastomosis is fine, then there are different techniques, transanal tube, or you want to do a ileostomy, depending on your requirement, you can do that.
There is one more question. Hypopharyngeal biopsy forceps. Can you show? I don't think we had you taken that photo. No, hypopharyngeal biopsy.
We have those biopsy forceps. They come with long tips. Particularly, they can have different angles depending on the requirement, right, left, or anteriorly directed if the tissue is in the post-recoid, and also for the vocal cords. So those forceps we have not added this time. So probably next time we'll add those. But they will be like the usual punch biopsy forceps, just that they have a long tip.
Manish has asked, sir, what is the difference between Lahaise and a right angle mixture?
So right angle mixture, I am familiar with. Lahaise, definitely I don't know. If Dr. Somshekhar knows, you can tell.
Lahaise is something like in between a right angle mixture and a tracheal dilator. See, right angle mixture is an acute 90-degree turn. Lahaise is in between a curved artery forceps and a right angle. So that it doesn't hook and create trauma like right angle, but the tips from the joint from the end is long, So it can take the entire pedicle. If you see the right angle mixture, it comes in multiple places, right? Small, medium, large. But still the largest is not adequate to sometimes hook the entire artery, vein, all of them as one pedicle. But Lajes comes with a not 90-degree angle, it is somewhere around 60 to 55-degree angle. And the instrument to the angle tip is quite long and curved. It is something like, a curved Setensky and this. That's the difference.
Is that used to hook the aorta?
Usually it is used to hook the thyroid pedicle in one bundle, superior pedicle, all of them together. So another thing, see, like there are some pedicles which run together. There are some pedicle which splay out, like for example, superior thyroid artery divided into anterior and posterior. When you go above, you get an angle between the both, and right angle mixture can take it if it is like a ureter or both artery vein running together or along. If the vessels are in a bunches, then the Lajes take all of them in one, which is good. Next question is Manisha asked, sir, can you just tell us in exam when they give an instrument, like how exactly we should start describing in an exam? Just any instrument, like how, see, like when you have an X-ray, we say this is a plain X-ray or a contrast CT, like that. So how do we start and explain any, and then we go?
The way is that first you should pick the instrument, then hold it the way you use it. The examiner expects you to hold the instrument the way you use it, not like holding the artery forceps like a nurse holding it from the tip. You hold the instrument the way you use it, and then like if it is a uterine manipulator, you have to hold the handle knob. If it is a forceps, you have to hold the way the forceps is held, the needle holder, the artery forceps. Similarly, the respiratory, when it's given in the hand, you should hold the way right hand or left hand, whether it is right hand or left hand. And if a drip cutter is given, you have to hold it, the circular stapler is given. You should know holding it that way, then identify the instrument and mention the functions where it's used and where you should be careful.
Yeah, see, exactly what he told. Hold it in the position you use, then identify the name of the instrument, and you tell if it is a lever mechanism, it is a type 1, type 2, type 3 lever mechanism. If it has a open close option, you do it. Then tell where it is used, what type of instrument it is. Power arm is here, fulcrum is here, this is here. Then you tell the salient feature of the instrument. Like for example, you have a tracheal dilator. So not to crush the trachea, it opens the opposite way. And then what is its speciality compared to other instruments? Like if there is a retractor, you can say, okay, this is a Devers retractor. So it is in curve, it fits the abdominal wall curve, and then also the tip fits the curve of whatever it retracts at the tip. Salient feature of that instrument compared to other, and then the uses of that. Then wait for the examiner to ask any special questions. I think more or less everything you answered. Q and
there is a difference between complication rates. Difference between complication rate between stapler and hand-sewn anastomosis. So a well-done anastomosis, whether it's hand-sewn or stapler, there should not be any difference in the complication rates, whether you do it vertically or laparoscopic or open. The only thing is, if you have not done it properly, then you will invite trouble. So we know that stapler is particularly used in the depth of the you are doing a colo anastomosis or a ultra low anterior resection, a colorectal anastomosis. Stapler comes handy because at the depth, particularly in the male pelvis, to take sutures, particularly the anterior layer sutures, is so difficult. So the staplers will save a lot of your time, otherwise retracting, struggling, trying to take sutures, visualization, light, and all that there will be issues. So the stapler will come handy. You know that staplers also, they may not fire properly, or they may fire off. So you can have problems with staplers also. They are not foolproof. They are all instruments. Your hands are the best guide for the anastomosis. So you have to take all the responsibility for the anastomosis. The only thing is that at the depths, particularly if it is a post-radiation surgery, you want to be careful. You want to have a good control and good secured anastomosis. So you would like to use the stapler. Otherwise, hand-sewn anastomosis we do in many places in the abdomen. We have not seen any extra risk of complication.
Absolutely. See, the students, the exam is none of the randomized control trial ever has shown any difference in outcome in a well-performed stapler or hand-sewn. The leak rates are exactly same as per the evidence, whether you do hand-sewn or stapler. So this is the thing. Only thing with stapler is, it is easily reproducible. Learning curve is short, and you can standardize the technique of surgery, and it is quick and fast. But the outcome, leak rates, everything is same. This is what exactly you have to say in exam. Sir, as per the evidence, the outcome leak rates is same in a well performed stapler or hand CN. There is no drug which has shown benefit as far as the outcome is concerned. However, stapler is little quick, fast, easy to standardize, easy to reproduce, but it comes with a cost. This is the exam you have to say. Okay.
Using sutures generally, it saves a lot of money to the patient, but ultimately complication, one extra stay or another resurgery means adds to the cost. You should always be careful with few things, that the vascularity of the transected margins, as you know that ICG also is used nowadays for endo or minimally invasive surgeries to look for the vascularity before transecting, or you control the pedicle first and then transect the bowel. And also there should not be any distal obstruction, there should not be tension in the anastomosis. You should know that if there is radiation given or the bowel is, the anastomosis is not that satisfactory, you better do a stoma, cover up stoma. So lumen approximations, this disparity in the lumen size, all those things must be looked into so that there won't be any problems later.
Good.
Why some instruments have gold color rings? See, gold color rings, finger rings is just not that. Those instruments are made out of special medical grade steel, very sharp or very delicate and very good quality. So most companies will have conventional stainless steel instruments, or some instruments will have the scissors, the vascular needle holders, the needle holders, or the not the arteries, it's the needle holders and the scissors, because they are delicate, they are fine, and then they need some good quality. Those come with gold color.
Yeah, I think a lot of questions are there, but we have to end. We are at 8:42. Thank you very much, Venkatachala. This is a very tough class. I can never take this. I'm so happy you have built up such a module. It shows the effort you have put it. And this is, I have not seen anybody who has built up such a beautiful slide deck. You should really improve it. And then every year before MCH, Surgical Onco and DNB, I think I should really invite you for this class. And now that you did and student gave an input, it's easy to improve it. But putting that first slide deck is phenomenal. Thank you very much. Thanks on behalf of students and DNB board. And students, this is a tough class. Please utilize it very well. And all the best for your exam, which is going to be in coming weeks in October. Thank you very much. And
thanks for inviting. Thanks to the DNB board for inviting me for this. Thanks to all the students.
Thank you.
Thank you, Dr. Venkatachala, and so much for your time. Now we can close the session, sir. Thank you.
Okay.
Thank you. Bye.
सूट जो नहीं मैं दिल्ली में गाड़ी में सीट के लिए